Welcome, everyone. Taking time out from you could be starting your holidays earlier. Anyways, today is the symposium presentation of Meena Mishra, who you all know, who's a PhD student, pre-doctoral NLM fellow, and she's going to do her symposium presentation, which is an overview of research that feeds into one starting to do their dissertation. So just a little bit of background. Meena previously worked here at OHSU in a clinical research role, managing and coordinating clinical trials in oncology and bone marrow transplant in the Division of Pediatric Hematology and Oncology in Doornbeckers. She has a master's in biotechnology from Banaras Hindu University, if I pronounce that right, and then also has an MPH degree from University of South Carolina before she moved to the Northwest. And so her research interests are in secondary uses of electronic health record data, and she's going to give us an overview of some of the areas that she's interested in for her dissertation work.
Thank you, everyone, for coming to my symposium today, in spite of it being the start of the holiday season. So I've been exploring the use of informatics tool to implement system-level policy. More specifically, I've been kind of researching how clinical practice guidelines, when applied at a system level, can take care of or give clinicians, help clinicians make decisions. So as I was researching this, I was reminded about this saying from Shakespeare, my famous play, Merchant of Venice. If to do were as easy to know what we're good to do, chapels would be churches and poor men cottages, princes' palaces. So as it is, it's quite hard to make that transition when from knowing what is good to do, actually get to doing it. But what if we don't know, actually, there's no clear light or path, and we don't know what's the right way to go about doing things? And that's where clinical practice guidelines comes in. Basically, it's a way of packaging evidence in the form of recommendations that a decision maker can use to make decisions to take care of patients. So this is the roadmap that I would be following today. I'll give you a little bit of background about prescription opioids, the significance of this topic, why are we looking at it, why are we looking at clinical practice guidelines, help make clinicians make better decisions to take care of adults with chronic pain. I'll then give you a systems view of the opioid prescription and discuss a role of CPG in that. I'd identify some gaps from the literature that I came across and kind of highlight a problem that is worth researching and propose some research questions. So what are prescription opioids? We keep hearing daily in the news. They are basically a class of drug which have morphine-like effects. They attach to receptors in the brain and spinal cord and other receptors in your body and interfere with pain messages. As a result, patient feels less pain. There are three different categories of opioids: natural, codeine, morphine, they are natural opioids. Semi-synthetic or man-made, basically they are made in the lab with natural product and natural chemicals. And then they are synthetic, like fentanyl, which are purely synthesized by chemicals that are not naturally found. So these prescription opioids actually are controlled substances. They are regulated by Drug Enforcement Administration, and DEA in short. And they are actually categorized from level 5 to level 1 in order of increasing potential for causing harm or causing risk for abuse, and decreasing potential for medical qualities. And as you can see, prescription opioids actually fall in Schedule 2. And so they have very high potential for abuse and dependence, though they do have some medicinal qualities and as a result can be obtained by prescription. Some definitions about that you'll come across in the presentation when I'm talking about adults. I mean ages 18 and over. Chronic pain is a pain that lasts for 3 or more months past the time of normal tissue healing. COT, in short COT, is chronic opioid therapy that lasts for more than 3 months. PDMP is a prescription drug monitoring program. This is a state-run monitoring program, an electronic database that collects information whenever a controlled substance is filled at a pharmacy. Then you'll come across DSM-5, which is nothing but Diagnostic and Statistical Manual of Mental Disorder, and currently it's in the 5th edition. OUD is opioid use disorder, and MAT is medication-assisted treatment. This is basically a treatment that is provided to people with substance abuse disorder. And what happens in this treatment is opioid antagonists are given to somebody who is abusing OUD. These antagonists actually bind to the same receptors as the opioids, and they help wean the person from opioid use disorder because these substances do not produce the same kind of response. They have a ceiling effect, so they don't provide the same kind of high or euphoria that usually an opioids produce. So to highlight some data from National Drug, from the CDC, as we can see that death from accidental overdose of opioid has gone up from 1999 to 2017. It has gone up almost 4 times. It was ranked, death from accidental overdose of opioids ranked 5th in 2017, the odds of dying from accidental overdose. And it's actually ranked over the odds of dying from motor vehicle accident. And if we consider just the prescription opioids, not the total opioids, prescription opioids constitutes about 35% of the death of the total, from the total opioid death. So clearly there is the role that prescription opioid is playing in the opioid crisis or opioid epidemic. Not only does it cause death as a result of overdose, prescription opioids also is a gateway for other kinds of addiction, like heroin. This is the data from NIH, where it's estimated that 4 to 6% who misuse prescription opioids transition to heroin. And about 80% of the people who use heroin first misuse prescription opioids. So these are alarming figures. And the reason for this is basically heroin is cheaper and easy to access on the streets. So here are some facts about prescription opioid. Problematic use of opioid is common among chronic pain patients treated with prescription opioids. There is good quality evidence that opioid therapy for chronic pain is associated with an increase in the risk for opioid abuse and opioid overdose. There's insufficient evidence regarding the efficacy of opioid for long-term chronic pain. And OUD increases, the risk for OUD increases as a function of dose at any given level of exposure. So we cannot say that this is a safe dose. We can start somebody at this and they'll be fine. And no matter at what dose you start somebody at, as you increase the dose or lengthen the time period of that dose, there's a risk for OUD. So why do we still prescribe opioids? We do so because considerable percentage of the US population actually deal with chronic pain. Almost 40% of the population. And there is 6 to 14% of this actually have severe and disabling pain. And as a result, opioid continue to be a viable option, treatment option for this population till we find better cure, which we are working on. So here's a systems view of prescription opioids. Basically, when a patient walks in with a pain to a provider, the provider has an option to put them on non-opioid pain medication, or they can choose opioid. The patient then fills the prescription at the pharmacy, and the data is collected by PDMP. The patient either takes and gets better, the pain resolves, or they continue to experience pain. As a result, they come back for more refills. And there's another decision point where clinician can make a decision to either continue with this opioid treatment or suggest some alternate way of dealing with the pain. If the patient stays on this pain med long enough, as early as 7 days to even as long as a year, within that period, the patient may develop opioid dependence. The opioid dependence can lead to opioid use disorder, or OUD in short, which can be diagnosed using the DSM-5 manual. There are a list of 11 criteria in that manual, and if you meet 2 of those criteria, it's enough to diagnose somebody with OUD. The symptoms of OUD can go from mild to severe depending on how many symptoms the patient meets. And this disorder leads to opioid-seeking behavior, as a result of which the patient displays some risk behaviors like diversion, illegally obtaining the opioids, or even getting addicted to heroin. And these risk behaviors can lead to opioid overdose. So this is in brief, the systems way of looking at what happens when somebody is put on opioid long-term or at high dose. So here are all the criteria that is listed in DSM-5 manual. Basically, there's a failure to fulfill responsibilities. There's use of opioids in physically hazardous situation. There's a craving, an uncontrolled craving for opioids. There's a lack of social or interpersonal, there's a problem related to social and interpersonal issues. There's a use of larger amount of or longer than intended. There's difficulty tapering opioids when recommended to taper. There is an increase in time spent to get opioid, use it, and recover from any taper clinician tries to do. The patient tends to give up on important aspects of their life. There's an ongoing use despair despite of the problems, and then there are some symptoms that are indicative of tolerance and withdrawal. So as a result of these issues, we have clinical practice guidelines. I already discussed what they are. And CDC, the most recent clinical practice guidelines are from 2016, which was also updated, I believe, around 2018, which is basically a recommendation, list of recommendation for risk reduction. They are essentially focusing on reducing harm. These recommendations come from systematic review of evidence, from observational studies, and from expert consensus. And I've already gone over it in brief, the evidence that came out with the systematic reviews. The benefit of long-term use of opioid is lacking evidence, is not supported by evidence. And short-term benefits of opioids, actually, there is some in terms of improving pain, but not improving function. There is insufficient evidence that long-term use of, for using opioids long-term for certain indications like back pain, headache, and fibromyalgia. So the clinical guidelines actually have a list of checklists that the physicians can look at when they are initiating or continuing opioids for chronic pain. They have recommendations for opioid selection, dosage, duration, follow-up, and discontinuation. But the thing that I will be focusing on mainly is assessing the risk and addressing the harm of opioid use. There's a list of checklists on recommendations where physicians are asked or recommended to look for risk factors in the EHR, to review PDMP data, to use urine drug testing, and to look for co-prescribing of benzodiazepines. They are a list of the kind of drugs that are given for anxiety, and they also cause respiratory depression like opioids do. And also, there's a recommendation to identify OUD and to arrange for treatment of OUD. So this is where I will be focusing mostly. For physicians, there are recommendations for physicians to look for known risk factors. And what are some of the known risk factors? Like illegal drug use, prescription drug use for non-medical reason, history of substance use disorder or overdose, mental health conditions like depression or anxiety, sleep-disordered breathing, and concurrent benzodiazepine. Again, other things to look for is urine drug testing and PDMP. So these guidelines actually are available to physicians in the form of clinical reminders. In EHR, there are dashboards or registries that the physician can use to monitor their patients who are taking opioids. There are some advisory text in the order sets that reminds provider to evaluate the benefits and harm. There's also the CDC prescribing checklist is available from within EHR for providers to pull up and take a look at while they are considering opioid therapy. There's also implementation of PDMP data from within EHR. So there's a way to integrate the data in the physician's workflow so they can review the PDMP data. There are documentation templates that are available to the physician so that they can attest to reviewing the PDMP and record any issues or findings from the PDMP data. So these gaps came up while I was reviewing literature and trying to understand how physicians are using the tools that are being provided to them. I basically came across that there was variability in the interpretation of opioid risk. There's underutilization of UDS, urine drug screen, and opioid use agreements. These are agreements between physicians and the patient when they initiate opioid as to the dose or the frequency of visit that the patients have to keep in order to continue on opioids. So there are underutilization of OUA as well, and also PDMP data. There are concern and reluctance among the younger providers to manage and prescribe opioids for their patients with chronic pain. Lack of time, training, and access to resources are perceived as significant barriers for taking care of patients in a busy primary care setting. Educating providers in opioid risk assessment did not change the rate of risk assessment in actual practice, even though there was an increase in the knowledge and attitude to do so. So here is a table from one of the studies that I came across where this is a result of a survey that was sent to the physicians and medical students as well, and asking them what are some of the information that they look for when they are prescribing opioids. And the physician said that looking at the information that they most often used when prescribing opioid was looking at patient's pain history and pain description. While they could have used, if the information was easily available, they could have used information like previous treatment experiences and average pain rating over the past week for making the decision. what are other things that are available in the clinical practice guideline that physicians could use to assess benefit and harm? The CDC also recommends that the use of some psychometric tools like ORT and SOAP to assess whether a patient is misusing opioids or whether there is a danger for them to use opioids. However, the use of these tools, there's a low quality evidence that it actually does any good. There's also lack of evidence in the EHR that EHR documentation is good enough for providers to make decisions. There's variation in the documentation practices, and different terminologies are used to inconsistently to document a problem of opioid use. So there is there was this study where they found that the prevalence of opioid misuse or abuse it varies very widely from 0% to 50%. I don't know where they got 0%, but it's making it challenging for a clinician or inform policy decisions or to implement and measure interventions. So I would go over this thing verbatim as it says, and so bear with me as I read it out aloud to you. It's also there for you to read with me. But this is an anecdotal comment from Dr. Mary Pickett. She's a provider here that prescribes opioids for her patients. And this is what she says. OUD chart footprint is hard. The reason it is hard is that it is such a sensitive topic for patients, and many have hard time accepting the diagnosis. So until it is severe, it is common for doctors to go light on the charting footprint. Sometimes it is left off the problem list. Sometimes it is charted in an obtuse way, like features concerning for, or not named at all. It can really break trust between patients and provider if this is added to the problem list or used as a visit diagnosis. It is commonly left out of diagnosis code, even when it's the main concern for the visit. There are some tools in the chart, including ORT, and I already talked about the evidence supporting the use of this tool. There are some tools in the chart, including the ORT flow sheet to screen for use disorder and DSM-5 flow sheet to screen for use disorder, but I do not believe we have an effective way to discern who and how many patients truly have use disorder by scouring charts electronically or even by doing a manual review of chart. Moving along, she says that in our opioid review board for our clinic, we go at lengths when we search a chart that we are reviewing to try to find hints of OUD in early stages. For example, I personally run a list of search terms one at a time through the chart search function to see if they have seen people who comprehensively chart pain, to see if they have signs of adverse effects or overuse. So, and she also lists some of the search words that she used to review the chart. So that's a problem. A clinician, a busy clinician, using search words to go one at a time and look through the chart to diagnose somebody with OUD is a huge issue. And what do we make of the data in PDMP? There are limitations in terms of accuracy, accessibility, and interpretability of the data in PDMP as well. The objective criteria, for example, for indicating risk behavior is if a person is filling more than 4 opioid prescription or seeing from more than 4 provider, it's indicate according to what's been provided, the recommendation is that there is a danger for or there is some kind of risk behavior that the patient has. However, many patients have multiple prescribers because of poor primary care access and because of visits to the ED for acute increase of pain. And there are conditions that require them to go to multiple specialists. So how do we interpret PDMP data in these scenarios? So I went through literature and found that there's insufficient evidence that PDMP implementation is associated with change in fatal overdose. However, there are certain administrative qualities and features that may help in getting some benefit out of the PDMP data. And these administrative features include mandatory provider review. That provider, absolutely for everyone he sees, should go in the PDMP data and review what it says or what he sees there. There's also, providing PDMP authorization to all providers who prescribe opioid is something that should be considered. Also, the advantage of push versus pull, where instead of every time provider going and looking into the PDMP data for signs of risk behavior, PDMP pushing this to the provider is another way of benefiting from the PDMP program. In addition, monitoring for non-scheduled drug, which is also beneficial. This is a qualitative inquiry study about clinicians' use of PDMP program. And again, I'm going to read, excuse me for that, but some participants of the program, which is the physicians, they mainly from the pain clinics, they report checking the PDMP with every patient every time. Others check only for new patients and for new opioid prescription or for patients for whom they suspect abuse. Participants described varied approaches to sharing PDMP information with patients, including openly discussing potential addiction or safety concern, avoiding discussion altogether, and approaching discussion confrontationally. Participants described patient anger or denial as a common response and noted the role of patient satisfaction surveys as an influence of prescribing. So this is huge. Like, even when they find something that indicates that patient is abusing or having some kind of risk behaviors, how do they bring it up with their patients? One of the things that providers are hesitant to bring it up with their patient is the patient satisfaction survey. Also, there is no study that evaluates effectiveness of policy, that CPG implementation system-wide, on the actual patient's opioid use behavior or misuse behavior. So putting it all together, these are some of the research areas that I have been exploring. There is a need to understand barriers and facilitators for risk assessment at opioid initiation, during opioid maintenance, and for chronic non-malignant pain. There's a need to understand how physicians are reviewing risk in the light of inadequate risk assessment tools, like the ORT, inadequate documentation in EHR, and inadequate systems like PDMP. We need to understand the effectiveness of CPG integration in EHR and patient actual outcomes, which is the misuse of opioids. And we need to get better at identifying patients with OUD so that we can direct them to MAT and alternative therapies. So these are some of the sub-questions under each question areas. What key factors determine opioid risk assessment and management by primary care providers? We can look at what are the information needs of the physicians for risk assessment. What information systems and tools do the physicians find useful when making prescription opioid decisions? And how do physicians interpret information in various information systems like EHR and PDMP to make decisions about opioid prescription? This is an interesting question. We all have come across this, that just providing the informatics tool is not enough, and that the informatics tool has to fit within the workflow of the provider. So we can look at is the PDMP access from within the patient EHR, does it improve PDMP utilization? There was a time when, as recent as this year, I think mid this year, when every provider, I'm talking about OHSU-wide clinics, had to go outside of the EHR, log into a PDMP site with their separate login and password, and access information about each patient. But there has been implementation of PDMP access from within EHR, and so we can definitely look at what role does provision of informatics tools inside in the provider workflow, what role does that play in the use of that tool? And does implementation of CDC guidelines in general in EHR result in better patient outcome or not? At OHSU, the CDC guidelines were implemented in the August of 2017. So there is a period of time that we can look at prior to and after that and see if that has improved pain and increased function, if there's increased identification of patient with OUD, or if there's increased referral to MAT services for patients with OUD. And of course, I mean, this has been my favorite. Can we improve the way the physicians can diagnose OUD? Can we improve, the time that the provider spends looking for the risk factors inside EHR and come up with some automated way of identifying OUD patients? So some methods that I have been thinking to address my research questions are, for the barriers and facilitators, definitely doing some kind of rapid qualitative inquiry using immersion and crystallization and purposive sampling. We can look at a grounded theory approach and identify concepts and themes and develop a theory. This is a checklist, actually, of that has been developed for implementation for chronic diseases. This is a tailored implementation of chronic diseases checklist. Basically what it is there are 57 determinants of practice change. When you're trying to change practice as how physicians should practice medicine, there are 57 different determinants that affect that change. And these 57 different determinants have been listed in 7 main domains. These include the guideline factors, which is nothing but clinical practice guidelines, individual health professional factor, patient factors, professional interaction, how the physician interacts with the peer, incentives and resources, capacity for organizational change, and social and political and legal factors. And all these 57 different determinants fall under these 7 domains, and they affect the change in practice. It's worth looking at these factors when I'm trying to determine, develop my theory for looking at barriers and facilitators for risk assessment for opioid misuse. So for the second question that I had was, how do we quantify whether there is integration of PDMP in EHR increases utilization or not? We can, there's a unique opportunity, as I said, at OHSU, where the PDMP access has been implemented from within EHR, and there are certain clinics that are able to access from outside of EHR. And we can identify if there are more PDMP queries or EHR documentation of PDMP data, and see if that makes a difference. And this is interesting. This is a slide from one of the survey results. Basically, it shows that 50% of the physicians said that had it not been for a separate login for PDMP from outside of EHR, they would have used the PDMP data. So there's a role that access to PDMP actually plays in physicians' use of the PDMP data. Can we look at what role Does clinical practice guidelines implementation play what role that plays in patient outcome? Yes, of course, we can do interrupted time series analysis and look at the patient PEG score, which is nothing but pain, enjoyment, and general activity score that's collected from before and after the CPG implementation in EHR, and see if there's a difference there. So this is, as I said, this is my favorite. Like, can we use NLP and machine learning techniques to better identify a patient with OUD? So here is an example of a table from one of the study that used machine learning techniques to diagnose patient with lupus. And they essentially used these different machine learning algorithms using different data forms, bag of words and CUIs, and found that neural network with the using CUIs had the best result, followed by random forest. So there is a role for machine learning to identify and diagnose patients, but we can definitely look at word-to-vector inversion because that's a more powerful technique when you have a lot of data, and it's a more powerful technique in this scenario where I'm trying to use OUD. It offers a way of identifying not just binomial classification of whether somebody has a disease or not has a disease, but at multiple levels, like whether they are dependent or they have misuse or abuse, and so they can be different categories of outcomes that we can look at using word-to-vector inversion. And it's a very powerful technique that I'm excited about. So it's not just enough to provide tools to make it easy for providers to look for things. What we should be striving for actually is providing a decision support tool at the point of care. And here is one such architecture where we can look at the structured data and unstructured data and aggregate it at a unified data platform, create some kind of unified data platform, and provide logic that flows from a care process models, and apply those rules and deliver knowledge at the point of care. So this is something like probably my postdoc or maybe later in years. Definitely something that's worth doing. So how does my research, how would that help? We will definitely be able to understand what factors are deterministic for successful implementation of the system-wide risk assessment policy. We can identify the role that technology integration in workflow plays in opioid risk assessment. We can look at the effect of system-wide policy on patient outcomes, not just, yes, we decreased the amount of opioids we're giving. Yes, we decreased, we increased the naloxone prescription for patient above certain dose limits. We are prescribing safer, but are we actually, improving patient outcomes in terms of improving their misuse of opioids? And definitely looking at NLP and machine learning techniques to better identify OUD would be a huge help. These are my references. I thank the NLM Training Fellowship for giving me this opportunity to research. The staff and mentors at DMICE, my symposium committee, Dr. Karen Eden, Dr. Nicole Weisskopf, Dr. Joan Ash, and Dr. Aaron Cohen. A huge thank to Dr. Mary Pickett for taking out time from her busy work as as it is, she's really busy doing what she should be doing, but she takes the time out to provide me information. Dr. Safina Qureshi, Dr. Wayne Bakeland, and the DMICE students and peers, I'm really, really grateful to you. Thank you so much.
Hi, Meena. Thank you so much for your talk. So I was curious whether in your discussions with clinicians or anything else you've read or that you've come across, if anyone, because you brought up that quote from Dr. Mary Pickett about like the whole like naming of the diagnosis being really at the core of establishing trust with patients, and how that sort of how actually writing that down in the EHR can be sort of problematic in itself. And I was curious to know whether you came across anything about like making time spent on patient education for opioid use disorder as a possible like quantitative metric that is used in any sort of way of recording. Hey, this is a thing that's going on with this patient, but isn't actually a diagnosis, but is a sort of quantitative measure of a potential health issue. So specifically, time spent on patient education for opioid use disorder.
Yeah, that's an interesting question. So I have not come across in my conversation. Definitely, education is a big piece of it all. Destigmatizing OUD disorder, definitely it's an interesting path that one can take. That do we provide some kind of education material to patients when they come in with the OUD, a potential for OUD disorder, or when we start them on opioids, if we provide them with educational tools, does it help?
More what I was getting at was the like actual recording of the time spent doing the education, right? Because that in itself like is sort of a marker of like, hey, this is something that.
That's a good point.
And you can track that over time and use it potentially. I'm not an addiction medicine specialist, but I'm curious to know whether.
That's something worth looking at. I'm not sure if they document the time spent educating, or if they are now how much time are they required to spend educating their busy primary
I don't think
care
there would
schedule.
Be any.
But definitely something that we worth looking at.
I think I had a kind of a different question related to the patients. You had talked early on about the patient satisfaction surveys and the relationship with the clinician, and I was curious whether any of the literature you saw or any of the things you've thought about in terms of the chart review are also looking at what is said in the patient portal for the patients, and how does it show up there, if at all. Because I think about some of these systems that can write things to your version of the chart. How transparent could you be or want to be about also writing some of that to the patient portal? Like especially if you're always checking the PDMP, like how much is that okay to let the patient know, this is just part of my practice and I'm doing this, and by the way, you can see here's the data about you, or not see the data about you from the PDMP.
So I did come across some, from doing some review, that in certain situations, I guess physicians do carry on some kind of communication with the patient directly about what they're seeing in PDMP. Again, it depends on how they perceive the patient is going to react, the patient barriers. So as far as that data being available in patient portal, I don't know very much about it. But PDMP data can be used as a platform for discussion between patient and provider to, deliver better care.
Interesting talk. Thanks for sharing. I was curious whether you had already or had any plans to sort of shadow some of those clinical interactions? I think you heard from people that they're highly complex, and a lot of these issues, they're not necessarily they're clearly not about technology, and some of those really complicated relationship dynamics, no matter what sort of system of classification we use to sort of try to instantiate those, they really will never be able to be fully captured. So I just feel like for you it might be highly valuable to get a chance to see that if you haven't already.
Yes, I have tried. So far I've been so busy with my coursework, I have tried to reach out to providers. I would be more than happy to shadow clinicians to gain better understanding of this problem and see, how we can develop the tools in the light of what we see. Definitely I'll be approaching more providers to see if I can shadow a few of them.
Talk. Thanks for this, and I want to piggyback off of that. Is your plan through rapid qualitative inquiry having an observational component, so understanding you could ask a provider, what do you think you need, but then to the point of the last question, what do you see or you perceive from that interaction as potential barriers, even though they had every intention to use the system? So have you thought about potential third factors that could confound whether this actually gets recorded? I was struck by your graph, your early graph that, no, that's fine. Your early graph that showed 2000 to 2013 to 14, there was a change in trajectory of the opioid-related deaths. Mm-hmm. And you would think at that time there was an increase in use of technology and using these decision support aids, yet the deaths go up. So there's potentially a third factor in there that might confound your results.
Yeah, that's. Thanks for bringing that up. So the increase in the trajectory that you were seeing was because of increased prescription of opioids to patients with pain. There was, long back, opioids were not the first line of treatment that somebody gave to a patient with pain. However, there was a change in perspective or the practice when pain was considered as a fifth vital sign somewhere in the early 2000s, late 90s. And that kind of escalated the use of opioids for pain. As a result, that the push that you saw that it increased was from that practice change that happened as a result of accepting pain as a fifth vital sign. And
actually 12 years later, though, the interesting point to me is that happened in the early 2000s, but that 2013 to 14 inflection point, you had increased prescriptions that whole time. But what happened in 2013 and 14? Maybe it was actually the physicians having these systems and limiting referrals.
Maybe unintended consequences of informatics tool. Definitely worth looking at.
Use and the high-tech act. It's. I think your point is well taken. Although we need to be careful about correlations. But one could potentially correlate the increased use of electronic health records, the high-tech act, meaningful use, but they probably don't have a lot to do with it. Actually, one of the few advantages to being older is that, you've seen these shifts. In the early 90s, there was a big concern about overuse of opioids, and then it probably went too far, and it swung back to the early 2000s where pain as the fifth vital sign, and now it's swinging back. So, the question is, what's the cause and the effect?
Thank you. My guess, as a actual chemical dependency counselor, would be that it was the introduction of Narcan that accounted for a lot of the decrease in deaths, because that became more widely available, and particularly for first responders, to just all they had to do is inject it into somebody, and you could kind of nearly literally bring them back to life. But I think that Chris's point is a good one, that I guess the fundamental thing for me is what did bring about actual change? And what patient outcomes do you use to measure that? Because it seems like from your review, PDMPs the use of them didn't really change things very much, although that could be because it was kind of difficult to access them. And how, do we measure it in like a decrease in the number of deaths? And if so, how do we connect that information to that information? Because it's not necessarily in the EHR. Do we look at that in terms of maybe the person doesn't show up in the PDMP again, and then we know, okay, they stopped using, or at least they stopped using prescription opioids. Anyway, I just wondered what your thoughts were about what brings about actual change in people's use behavior and what outcomes would be best to actually measure that.
Well, that's a huge question. Like, there are so many theories that have been developed to, help us understand what brings about change in behavior of anyone. In the light of like, what should we be even looking at? Like, are we changing actual patient behavior or patient outcomes or not? It's a very complex topic and very hard to measure. How do we, look at what kind of data do we look at to even say if the patient there's a change in the patient's misuse of opioids? What if, again, as you said, they might not be going to another provider, they may be using heroin on the street, and the data is not being captured in EHR anymore, and we are thinking maybe they're not using anymore, but, we don't know.
So given that fact, and also kind of the majority of the questions that people have been asking, I wonder if the best outcome might be to look at the trust between the provider and the patient, right? Because it seemed like people are kind of, based on these questions, interested in that topic, and it's true that that's important. I think that's the number one.
Definitely, we can measure the trust. I don't know. They could be a good way to measure that, develop tools to measure trust. That's another research question out there. Looking at, again, looking at patient satisfaction with their quality of care is probably not a good measure. So, that's something interesting to explore. Thanks for bringing it up.
Just going off that question, I know that you said you were planning on looking at pain scores. Were there other instruments that you were planning on looking at? I'm not remembering.
Pain score or PEG scores are one of them, but since the clinical practice guidelines do recommend looking at utilization of urine drug test, if there's a change in rate of that.
But in terms of like the patient-facing thing, one option in terms of looking at outcomes would be if there are certain quality of life instruments that are used frequently in the clinical setting, which would be something to ask a clinician about. But I know there are certain promise tools and things like that, so if any of those are frequently integrated into the care process, it would be another option.
That's a good suggestion. The PEG score does look at some aspect of it, like they do have score for enjoyment. They kind of reflect whether the patient has improved in terms of quality of life, but not in a very detailed way. But definitely we can look at tools and consider that.
Thank you. Came back to slide 26.
Oh. Let's see. Slide 26. Sorry. We should have gone the other way around, but anyway, now that I've started.
want to use the natural language process to predict the patient the risk for OUD or
To
determine.
identify patients with OUD.
But the OUD was the diagnosis by DSM-5, right?
Yeah, so as I said that the OUD can be diagnosed using at a minimum 2 of the 11 criteria that is listed in the DSM-5 manual.
So there any problem for the, DSM-4 DSM-5 diagnosis? Do you have any idea? Can we have some structure here, data for determining patients?
So we do, providers do have a flow sheet in which they can record, DSM-5 criteria. But as I said, they are hesitant to do so. They don't want to unless there is an extreme cause for concern because they don't want to break the trust between them and patient. There is that aspect of it that prevents a provider from explicitly documenting, but they do, and as Mary Pickett said, that instead of calling it an OUD or documenting in a flow sheet, she does put some symptoms in the chart for her, for people who are doing review of these patients. So there are breadcrumbs that we can follow, but not an explicit OUD terminology that's used.
So you want to
often.
use a natural language process, got some information from the clinical notes,
Yes.
and help to define the patient that they should be diagnosed as
OUD.
but they didn't.
Didn't.
So is there any paper to explore the how many percent or the problem of the patient they should be diagnosed as OUD but they not?
No, that's a good question. It's maybe something that I can look and write a paper about.
Yeah, that's an interesting question.
And thinking along those lines of clinical entities that that have things that have a lot of stigma, and they require a whole lot of strong QI to really improve results on. I'm thinking like obesity would be a really common one that has a pretty good bit of stigma. We're told all the time, that you can push things, but it's pretty hard to get that moving. Sometimes I'm thinking about like domestic violence, but then also sort of the whole field of psychiatry and psychology. So I wonder if maybe there's some literature on a parallel topic, where they've tried to use NLP to detect things for some type of, high stigma psychiatric diagnosis or something. And then I have one other idea is that Oregon, I believe last year was the first year that they've required all licensed providers by the Oregon Medical Board to complete a little video training on substance. I think it's like the nature of pain and alternative treatments and things like that. And I wonder if maybe there's some ways to look at before and after, or if there was a group of folks that got it earlier on or later on, or just an idea.
No, that's a good suggestion. Yeah, there's a lot of education going on in the provider sphere to educate them about substance use disorders. So yeah, we can definitely look at that.
Last question I have for you is just from your perspective, it seems like you could focus on the conversation with the patient and whether it's getting into the note, whether they're using the PDMP, whether they're using guidelines, adherent care, or whether there's some outcome for the patient. Define it how you will.
Mm-hmm.
Which area interests you the most, or do you feel that this is the one that's going to get the most bang for your PhD buck?
It's very hard to say that. These, as we have all learned, caring for patient is like it's within the sphere of this socio-technical aspect where you have to look at all aspects to provide quality care. My personal bias is I like machine learning and the use of technology to better identify patients, something that I would love to do, and provide information that the provider need at the point of care, not looking into the different places to combine the whole picture, but looking at the point of care. So definitely something that I would love to do, but understanding, in order to develop that tool at the point of care, we need to understand what's going on, actually, what are the information needs that we can bring together to make a tool, and that in order to understand the information needs, definitely, we have to do some qualitative study. So doing the qualitative piece, and then doing, some kind of a informatics tool is my dream research project, something that I am looking forward to do.
One more question. I'm wondering if it might not be useful for you to study someplace besides OHSU, or in addition to OHSU. But it occurs to me that, well, you're talking about EPIC specific, having this access. There might be other EHRs that have a different kind of access. There might already be some decision support out there that would help with this. But I'm specifically thinking about federally qualified health centers, and if there might be a different level of trust and different dynamic that's more socio-technical. So I hate to give you more work, but that would be my suggestion.